On April 2nd, we will be implementing a best practice standard of reducing the use of oxygen in patients. The purpose is to use only the minimum amount needed to keep a patient safe while they stay in our hospitals. Although supplemental oxygen is valuable in many clinical situations, excessive or inappropriate supplemental oxygen can be damaging. A recent systematic review and meta-analysis has shown that too much supplemental oxygen increases mortality for medical patients in the hospital, including patients presenting with myocardial infarction. Until recently, healthcare professionals believed that oxygen had little or no harm for acutely ill adults. We now know that patients exposed to liberal oxygen were more likely to have adverse outcomes. The increase in mortality was highest in the trials with the greatest increase in SpO2. We base our best practice protocols on the findings and recommendations of the British Medical Journal, the American and British Thoracic Society, and the European Respiratory Society. Until recently, many healthcare professionals believed that oxygen had little or no effect to acutely ill patients. We now know that patients exposed to liberal oxygen therapy were more likely to have adverse outcomes. The increase in mortality was the highest in the trials with the greatest increase in SpO2. We based our best practice protocols on the findings and recommendations of the British Medical Journal, the American and British Thoracic Society, and the European Respiratory Society. These recommendations were reviewed by our group of 6 intensivists at the Oklahoma Heart Hospital. We felt the following should be implemented in our clinical practice at OHH. The essence of our recommendations can really be summarized simply by targeting a saturation range, applying oxygen when the patient falls below that range, and monitor to remove oxygen when the patient tolerates. This includes patients in the emergency room and patients with chest pain. Remember that oxygen is a drug, and clinicians must chart each time a patient is placed on oxygen or taken off. So, what's our goal? Reducing the FiO2 to the lowest tolerable limit. We have reduced the complicated algorithm into 2 simple guides for you. The patients without lung disease, the goal will be to keep the SpO2 between 92 and 94. Look for the green areas. If your patient is in the green, do nothing. If your patient trends toward the red, remove the oxygen. If your patient is trending towards the blue, add oxygen. In patients with COPD who do not use home oxygen, the goal will be to keep the SpO2 between 88 and 92. If the patient is on home oxygen, please refer to the pulmonologist or attending physician. There are a few exceptions to this rule, such as carbon monoxide poisoning and some untreated pneumothoraces, that the attending physician and/or intensivist will guide your target SpO2 values. If you're responding to a RAT or a code blue, always place the patient on oxygen without thought for the SpO2 until the patient issue is addressed and solved. If there are special circumstances with the patient, the attending physician or intensivist will guide the oxygen and target SpO2 for you. Need resources or guides for your patient? Call the respiratory therapy team to help, or use our patient education sheets that are available in CRAMES and on the intranet in other forms. This will help to educate our patients on why we are reducing the use of oxygen in our hospital. Thanks for doing your part in making OHH the best.